this is exciting for us because we've known John from Darko, and we've been, familiar with Darko as a company for a long time, but they've just this year come and joined us as a sponsor. And so we're so glad to have them. And this is our first webinar that we're presenting with their content. So, thank you to Darko and John for putting this together for us. And tonight we're going to talk about offloading and early intervention. So, Sarah, do you have anything else before we turn it over to John?
I don't think so. Like Ann said, make sure if a question pops in your head, ask right away. Don't hold it until the end because we will see it. And no, I think we are ready to get rocking and rolling. So, John, we're going to let you introduce your speaker, and we're going to hide in the background.
Yep, we're going to turn off our cameras and our mics, but we are still here listening, so we can pop back in at any time. And with that, John, take it away.
Great. Thanks very much, Ann and Sarah. Thanks to everyone for your time this evening and for logging in. I'm very pleased and proud to present our speaker this evening. Darko has had a relationship with Myra for several years. We trust her greatly. Her expertise is unsurpassed, we think, in the industry as far as wound care experience is concerned. And she's seen it all. She's done it all as far as wound care and offloading. And we're very pleased and proud to have her. With that being said, I'd like to introduce Myra Barnado. She is our presenter and speaker this evening. Myra has many years of experience in the wound care industry in various responsibilities. She started out early on at the Carville Institute in Louisiana, and using Ortho Wedge and Felt to offload wounds and ulcers for the patients down there. And she's not stopped since then. She currently works for Corstrata, and I'll let her explain a little bit about what Corstrata is all about. And without further ado, Myra Barnado. Myra, thanks, and looking forward to this.
You bet. Hello, it's so great to be with you all this evening. As John said, I work for a virtual wound care management company, which we'll talk a little bit about some virtual opportunities later. But what we're going to be talking about tonight is offloading and early intervention, and then what to look for in patients who have neuropathy and they're at risk for diabetes foot ulcers. Okay, so a little bit of background. As John said, I came through the LSU health system. It was the charity hospital system. And we were a safety net for underserved, medically underserved and socioeconomically underserved patients in South Louisiana. So in 1997, LSU took over the management, the clinical management of the charity hospital system. And the only way they would do it was if they could have it written in the legislation that disease management was going to be the practice that we would assume. So that was back in 1997, and disease management was not really well practiced at that point. So in starting a disease management initiative, we had certainly standardization of our processes and the care we would provide to our patients. We followed evidence-based practices. We educated not only our clinicians and our staff as well as our patients. And so education was a big part of this. We collected our data and we evaluated our clinical outcomes because that would tell us what we were doing well, what we needed to do differently, that kind of thing. And then throughout time, we established telemedicine programs across South Louisiana. In that, I just want to just give you an idea of what our program focus was. It was to improve health status of our patients in South Louisiana, as well as to optimize the healthcare dollars that were being provided to us from the state. So we started off with just the very prevalent chronic diseases that we saw throughout the state, and it was like CHF and asthma, Hep C, and renal failure just to begin, and then of course diabetes. So I want to talk, and I need to say this now, tonight we're not really talking so much about PAD and neuroischemia as much as we really are talking about neuropathy. And I want to just kind of go over some other disease states that are besides diabetes that patients can have neuropathy and unfortunately amputation. So, and I've seen patients in every single one of these. So, you know, pernicious anemia, your patients who have spinal cord diseases, HIV, AIDS, chemotherapy drugs, drug therapies for AIDS, for example. And then our patients who have congenital insensitivity to pain, which is really kind of a tough thing to try to manage, Charcot-Marie tooth disease, tall people, and then of course celiac disease and participating in our program tonight. And as you can see, it's a variety of different amputation types, but you know, it was really a big problem in our health system, and we saw a lot of amputations. So just to give you some updated amputation statistics, we know that over 200,000 non-traumatic amputations are occurring now every year in the United States. With African Americans and other minorities being 4 times more likely to experience these amputations than white folks. In the US, someone is diagnosed with diabetes every 17 seconds, and every single day, 230 Americans with diabetes will suffer an amputation of some type, whether it is a toe or it's below the knee or a transmit, whatever. So, you know, for a while, there was a great decline. We were really excited because the rate of amputations had decreased. But then we started seeing a tremendous increase of about 50% between 2009 and 2015. Okay, so the numbers went up to 4.6 amputations per 1,000 adults less than 64 years of age. And we think that the reason we saw those that increase among those age populations was because many of them had a lack of insurance coverage. So this is a good reference for this if you would like to look it up. And as we go through, I don't have references on everything, but if you would like to have those references, I'd be more than happy to provide you with them. You'll have my contact information in a little bit. Okay. So this is a really old slide, but you know, it's tried and true. It's, you know, it's just, what is that pathway to lower extremity amputation? We know that 72% of the time, the most common pathway leading to a lower extremity amputation in diabetes is a minor trauma, an ulceration that forms, and then faulty healing. And when you think about that, you know, they are minor traumas a whole lot of the time. But they can absolutely relate. They can absolutely result in a lower extremity amputations. So what are the conditions that we need, conditions that are present typically when we see a patient with a DFU? Sensory loss and abnormal foot pressure. Those are definitely associated with plantar ulceration in particular. We know that those foot ulcerations are typically going to occur over the highest pressure sites. And we have to remember this, it's not just the sensitivity, okay? It also has to do with foot deformities and joint limitations, rigid ankles, rigid toes. And those are definitely associated with that high foot pressure. So it affects not only the sensation or neuropathy, you know, there's the other component of gait and motor neuropathy as well. So, okay, we looked at some amputations. Now let's go back and let's kind of step back a little bit, and we're going to look at some more familiar images that we may have. And I tried to put in a variety of different sites, and as you can see, most of these are going to be plantar. Okay, but that's not to say that certainly we see DFUs Certainly, we see them distally, we see them laterally, we can see them in the dorsum, interdigitally, we see them everywhere. But just to name these, a midfoot Charcot foot deformity. Then we have a first metatarsal head wound, plantar heel, distal great toe, then that IP joint of the great toe, which is one of the most common reasons for a great toe to be amputated right here. And then, of course, heels sometimes. Well, one of the things, it's easy to get pretty overwhelmed when you're managing these patients, not just because of the wound, but because of the comorbidities that they suffer, at the same time. So these patients can be very complex. So what we realized early on in our program was that if we could simplify this as much as possible and really not get too out in the weeds with everything, we knew that that would help. So one of the first things we did was, say, okay, well, let's see where, if a patient has a wound in a certain location, what does that tell us? Does that give us any idea as far as like factors and causation? And we found, yeah, it absolutely can. So for example, that IP joint of the great toe, we know what's happening there typically is that they've got inflexibility of the great toe. And that happens very much related to glycosylation of the structures in the foot. And they have shortening, and you'll also see inflexibility that will ensue with that great toe. So when that individual is stepping in the toe off phase of taking a step, there's no flexibility. Okay, their foot is just, their toes just kind of going smack down, and then they push themselves to go forward. The met heads, a lot of times what we would see is there was a lot of prominence among those metatarsal heads. And the other thing we know is that you'll get some shifting, and some of this has to do with age, but this very much has to do with neuropathy, shifting of that metatarsal fat pad distally, over the met head. And again, ankle, a decreased ankle flexibility. So, I don't know how much you ever think about that, but that's huge. That's really huge. If they don't have flexibility, then they're not going to be able to take a proper step. Other sites would be dorsal distal toes, and sometimes that's from a claw toe deformity. It can be from shoes. It can be from wearing shoes that have, for example, if they have a claw toe foot deformity or toe deformity, that they wear shoes that are having a very shallow toe box, or that the shoes are too small. Okay, and we need to remember these folks have neuropathy. Okay, so they may be totally unaware of many of these things happening unless they have really good, daily care, daily foot hygiene, doing their foot exam and those kind of things. Then, of course, medial lateral forefoot, we'll see that with deformities such as, bunions, again, shoes. We can say shoes all night, and I know you know what I mean. They definitely have a lot to do with some of these problems. And then some of these patients, again, remember, they may have renal disease, and it's very common that you would see among patients who have neuropathy. It's a microvascular manifestation of diabetes. Okay, neuropathy is renal failure. Okay, as is retinopathy as well. Those are all you see them commonly, among this population. So they don't just have neuropathy. They have neuropathy plus they have retinopathy, and they may have nephropathy as well. And then, of course, the plantar midfoot. Anytime I know a patient has a midfoot plantar wound, my first thought, if I know it's not a direct injury from having, for example, stepped on a nail or stepped on something that perforated, penetrated the plantar surface, then I'm thinking a Charcot foot. That's my first thought. And I will tell you, having worked in a very, our program was a very focused limb preservation program. And I will tell you that I think probably Charcot foot deformities are very much under-recognized, unless you're really looking for them. So the other thing, again, we would see sometimes these edema blisters, and that all goes together. So here's some, causes of direct injury that you would see. And as you can see, everything I've listed here actually is in the house. And, it's really important that we make that we distinguish that, patients can have injuries in the house as well as outside of their home. So, any one of these issues can certainly happen. One thing I want to mention is like the little Legos. You may have a patient who has that in the end of their shoe. And if they don't actually try to see if, there's anything in the shoe, they may just walk around with the Lego in the end of the shoe, and they can really get some bad wounds from that kind of thing. It's crowding out the entire, the foot. The other thing is hot water bottles, heating pads, patients putting their feet up on, if you live in a cold area where you have fireplaces, you need a fireplace, fire. Those folks, again, they're neuropathic, so they may not realize when they are putting their feet up, and they may have, they have shoes on. Well, they may not realize that their shoes get really hot. Okay, and then that will transfer to the feet as well. So that's kind of a big deal. And then, of course, some common injuries being from shoes. Now, some of these are really old, but I just could not resist putting them in because, there's somebody here that wore some of these shoes, I'm sure, back in the 70s. But these are all shoes that can really cause injury. And, when we're talking to patients about what type of shoe we would prefer them to wear, we have good evidence for all of this. We want them to have a shoe that has a removable insole, that has a nice soft outer sole, that it is typically we would like it to be, well, certainly the shape of the foot. And then also plenty of depth in that toe box. That's really, really important. Okay. But you can see what's the effect of high heels on the feet. Well, there's a lot of pressure that's being put there on that ankle, as well as down on the met head there. All right, so that's really not a real great thing for patients, particularly neuropathic patients, to wear. So, just the basics. The shape of the shoe should match the shape of the foot. That's just real crucial. That's not rocket science. It's not hard to figure that out. One of the things we would do is we would take a tracing of the patient's foot, and we would give it to them to take home, and we would tell them, okay, you need to take your shoes and you need to place your shoe over the tracing. And if you're seeing the tracing outside of your shoe, then that means you're not wearing a shoe that's large enough. All right, and that's an easy way for patients to be able to figure that. So then, we looked at all those different types of wounds, and we know they can occur, all over the foot. But let's just focus just on, some really very specific sites where we know most commonly DFU's wounds are going to occur. Okay, so I will tell you, you don't have to add all these up. I can tell you that 59 to 60%, we'll say, of these plantar ulcers are in the first, the great toe, then the first met head, and then the fifth met head. And you'll notice that the other met heads, like the second, the third, they also have higher rates than the remainder of the foot. Typically, DFUs don't occur unless it's a direct injury so much, or they have a true gait abnormality and they have a slap foot on the heel, on the plantar heel. Okay, that's just not real common. And then, of course, when you get in that midfoot, that's when we start wondering about, certainly the Charcot. So, all right, so we looked at amputations, and then we went back and we looked at, okay, we had the amputations, and we're going back and we're looking at, okay, these are the wounds, and we know that the wounds precede amputations. It's very clear, very clear. The data tells us that, the evidence tells us that. And so now let's go back and look at the different types of deformities that we commonly are going to see. Okay, so let's look at claw toes. Okay, claw toes, very common, very common. So when I'm talking about claw toes too, this is the perfect example of one. The distal aspect of the toe actually becomes plantar. All right, so that's a really good way for you to see that. And you can see this person has other deformities. They have a bunion deformity. And, once these start developing, they can really lead to some big problems if they're not recognized. All right, and I do want to make mention of this claw toe here. This is a patient who had an amputation of a great toe and a second toe. You can still see there's their surgical site, but guess what? They didn't used to have these claw toes, but after the surgery, there was some shortening. I mean, it's just changes in the musculature there with those adjacent toes. And what you will see commonly is that they become clawed. So my point to you with this one in particular is, okay, you see that after the surgery. Okay, don't wait for that to become a bigger problem than it is now. Understand that this is already a problem waiting for another amputation, okay? And then, of course, this IP joint of the great toe, very common reason for a patient to have a great toe amp. And some people will say, well, that's a minor amputation. In my mind, a great toe amputation is a really, really significant, troubling amputation, because what I have seen in my experience, and when you look in the literature, it'll pretty much tell you, you get one amputation and then within a couple of years, you may have another one, and within 5 years, I mean, we're really in trouble. And I've got some of those statistics for you in just a minute. Then we see, let's look at that metatarsal head prominence, okay? Because that was the second most common reason for a patient to have wounds, okay? So you can see that metatarsal head prominence. And one thing I'll mention to you is that it's not uncommon that you would see not only metatarsal head prominence, but also claw toeing as well. And it has everything to do with just changes, the musculoskeletal changes that are taking place in that foot. And then we see other forefoot issues. Okay, so this, rather than put out 3 different slides, I figured this kind of covered a whole lot of everything. All right, so let's just talk about some real common forefoot issues that we may see. Well, one is crossed up toes. I had a patient who called them jacked up toes. Well, it all means the same thing. All right, so that is clearly a foot that, those toes are in no way aligned, or, they're just not right. Okay. And you'll also get some interdigital rubbing. And the problem with interdigital rubbing is, you've got the bony, you have the bony apparatus there, and it's rubbing against another bone interdigitally. And, the reality is there is not a lot of soft tissue in that area. So it's not at all unusual that, you'll have patients and they'll develop calluses there. And, once you debride that callus down, you've got a wound. And guess what? Sometimes it's down to bone. And that's why interdigital is a big deal. It's a really big deal. And then, of course, the bunion deformity. And these are all related, again, just changes, musculoskeletal changes that occur. Charcot foot, I could talk about Charcot for 3 days. I won't, but there's just a lot to know about them. And this is a stable Charcot. Well, it's a little bit hot, you can see that, but it is without a wound. And we know that patients who have a Charcot and they have a wound are 12 times more likely to have an amputation, okay, than folks who don't. So if somebody's got a Charcot, it's so important that we try to maintain it as a stable Charcot. All right. But for someone to develop a Charcot, these are typically what you'll see is they have sensory and oftentimes autonomic neuropathy. Okay. So you're getting into arteriovenous shunting and that kind of thing of blood. You get some hyperemia. And typically this is what happens. They have an unrecognized injury, and we all do this. We step funny off a curb or something like that. Well, if you don't have neuropathy, you know, wow, I may have strained my foot, or I think I hurt my ankle or whatever. And you are going to change your gait based upon your perception of pain. Pain is not pleasant, but it gets our attention very quickly, and it helps us to make changes. And then it's an unrecognized injury. They're insensate. All right. So then they continue to walk on it. They have repetitive trauma after that injury. And then you get into that hyperemia, and that is essentially what is happening, and this has to do with the autonomic component. You'll have a shunting of blood to that area. It's an inflammatory response. Okay, but what happens is it just kind of sits there and it demineralizes the bone. So what you will have over time is, just total disintegration of the foot architecture. Okay. One thing I will tell you is typically these folks have adequate blood supply, and seldom do you see them have PAD, at least originally. Now, it certainly can develop later on, but at the beginning, the origin of Charcot, you typically are not going to see PAD so much. So, all right, so we've looked at all of this. We started with amputations. Then we looked at different kinds of wounds, and now we're looking, we just looked at some, common foot deformities. So, the question is, how are we going to identify patients who are at risk? Okay, well, I'm going to tell you, that's one of the things that we did very well in our program. As I told you, our patients were medically underserved. We were the safety net. So we knew, okay, typically the way patients would get into our system was they went to the emergency room. And people would actually tell them, oh, you got to go to the emergency room to get into that system. Well, that is just horrible. Okay, so that was one of our goals. How are we going to decrease ER visits? How are we going to keep our patients out of the hospital? So what we ended up doing was, in that process, we ended up just really blowing up our outpatient services and had, ready availability of care for patients who needed it. If I was doing my job well and a patient called me and said, oh, I think I have a foot problem, I should say, how quickly can you get here? Okay. And that was very much what we did. We very much did that. So, the only way we know to do that, though, was we identified our patients who were at risk for a DFU. And there's just a very, this is not rocket science. This is a program that started at Carville. I don't know if you're familiar with Carville. Carville was a Hansen's disease center around the turn of the 20th century. And, Hansen's patients came from all over this hemisphere. Typically, they're in areas that are tropical, subtropical kind of climates. But what we realized was that there were, over time in that program, that once leprosy, Hansen's disease, was cured, this program was under the auspices of the Surgeon General, who said, okay, you've got all this great research that you've done with leprosy. Is there another disease state that you could use it with? And there sure was. And that disease state was diabetes. So much of what we know about management of diabetes-related foot ulcers actually came from management of leprosy. So the things, that are so important in doing this, and we did this through our primary care clinics, comprehensive foot exam, it's a standard, it's a national standard that every patient who has diabetes has annually a comprehensive foot exam. And what happens then is, you're identifying current foot problems, really identifying that risky foot, and then making a prescription, appropriate for prevention and then treatment based upon the risk level. Okay. And by prescribing, it was really more in the terms of footwear and those kinds of things that we could do that could actually help manage some of their gait abnormalities, because we would see those so commonly. So the way we did a comprehensive foot exam, there's certainly more to it than these tools, but you're probably familiar with these. A monofilament, typically loss of protective sensation is, that's defined as being the level of sensation that someone would need to know that they have an injury. Okay. If they don't feel the monofilament, they have loss of protective sensation. And that is with a 10-gram monofilament. The size is actually a 5.07. monofilament. And I was really lucky because the fella who did that research was the one who really taught me everything that I knew. He was a PT. And I was very fortunate to work with him because he did some really amazing research, and it was very, groundbreaking kind of research. Then also, vibratory tuning fork, that's very good. And that helps, particularly when you're looking at things like proprioception. And one of the things I will tell you is there are plenty of studies that say vibration is probably one of the earlier signs that someone has, loss of protective sensation, maybe than even a monofilament. But then another tool that we used was infrared dermal thermometry. Now, we were using thermometers back in 1997. It was amazing because they were very hard to find. Our doc who developed the monofilament research, he did a study, and for the reasons that we would need to know what the dermal temperature would be, he found that the $14.99 thermometer, infrared thermometer at Radio Shack, for our purposes was sufficient, okay? And what we were looking for was a temperature difference of 2.2 degrees centigrade, okay? If a patient, for example, if they had a wound on their left met head in that area, then we would compare that temperature in that surrounding tissue to the right med head, first med head. And if we saw that, the site that was affected had that increase in temperature, we knew it was inflamed. David Armstrong and Larry Lavery did some really groundbreaking research back in the early 90s on non-contact infrared dermal temperature measurements, and they really did qualify the 2.2 degrees centigrade. So then we had a screening tool, and this is the one that we developed at LSU. I can tell you that there's other groups that use other ones. They're fine. There's, all I have to tell you is there's just certain things need to be contained, okay, every time. So just to begin with, I'm not going to go over these questions right now, but, typically you would take, the monofilament, and then if the person was amputated on the right, then you just did, you just marked out the right. And then every time the patient was able to detect the monofilament with their eyes closed, then we would put a plus. If they didn't, it would, we would list a minus. We only did one for the dorsum of the foot. All right. Now, for ours, we didn't do the heel. And the reason we didn't was we felt like you got some false readings with trying to identify monofilaments in the heel, partly because, as you know, it's a different kind of skin. So a 5.07 or a 10 gram may not be adequate really in that part of the foot. And the other thing was, if you go back to the photograph that I showed you, that's just not really prevalent. So we pretty much stuck with, first, third, fifth toes, first, third, fifth met heads, medial, lateral forefoot, and then the dorsum of the foot. Okay. And then we had, a bunch of questions that we would ask. All right. And some of these were observational. Okay. A lot of them were, some of them were questionable, questions that we would ask the patient. But when we were able to identify, I've highlighted them here for you. Okay, these are all like, I should have put them in red. These are red flags. Okay, these are red flags when you're seeing now I'm talking about just doing the yearly comprehensive foot exam. When you've got a patient that is having some of these issues, that should tell you this is a person who is really very much at risk. Okay, now let me show you. Let me go back one slide real quick. And I'm sorry, I don't know that you can see how well you can see this, but we place the patients in risk categories based upon the results, okay, of our questioning and then of our assessment. All right. So Risk category 0 was no loss of protective sensation. And then 1 risk was, yes, they had lost protective sensation. 2 was they had lost protective sensation and they had, callus or a foot deformity, or they maybe had, a neuroischemic foot. And then certainly the highest risk category was a patient who had already had a plantar ulceration, or they had, a Charcot foot, or perhaps an amputation of some sort. Okay. So based upon the level of risk, we developed some management of these patients. So in doing that, what we were able to do was we were able to stratify patients, the risk for problems with the corresponding management plan, which was, that was kind of a nice guide to give everyone. And it provided guidance to not only caregivers and patients, but it also helped us to identify the education plan for that patient. We had a lot of education courses for our patients. And back then, those were all in person. We knew that the only way that this was going to work with this management was, I'm a nurse, I'm a wound care specialist and a foot care specialist nurse, but, I learned a lot from my PTs, but I sure as heck don't know what PTs know about the foot. Okay. So it was absolutely essential that you had a collaborative, multi-disciplined effort in trying to take care of these folks. And then, again, just promoting the disease management that goes with prevention and of not only diabetes foot wounds, diabetic related foot wounds, but also lower extremity amputation. So one of the things that was really, really, really important, and if I had to tell you one thing early on, this was probably the biggest focus of our program, and it was offloading. And you hear a lot about offloading, okay? But what is it really? It's it's a practice of identifying the sites of highest, particularly focal pressure, and then redistributing that pressure over a larger surface area. All right. So the offloading modalities are used to address pressure sites that are neuropathic. Okay. It's the foundation of neuropathic wound prevention and diabetic foot ulcer management. Here's the bottom line. I can put all kinds of skin subs on that foot, but if the patient gets down and they walk on it, well, we just wasted a lot of money. Okay. So, we've got to make sure that this is something that is just so basic and so essential to be, to be identified and to give attention to, because it's a big deal. In our system, we didn't have a lot of money. We didn't have money for HBO. We had access, but we couldn't afford it. There was just a lot. That was kind of before skin subs. I think we had some autologous stuff that we would do, the PDGF maybe. But that was expensive too. So, what wasn't so expensive was if we identified that foot at risk, and then we identified, okay, this is the appropriate thing that we should do. And it would certainly be in looking at the offloading and removal of that focal pressure. The other thing about offloading is, you're also considering gait abnormalities, and you're considering management of the soft tissue loads. Okay, so that's all really, really important when you're trying to come up with a plan. It's not unusual that many of these patients have gait abnormalities, as you well know. So that has to be considered as well. And then one thing that is so critical is offloading will occur for a patient at all points in the patient's journey, through remodeling for sure. And then unless the deformity is corrected, lifelong. We'd let our patients know that, this is not going away. Unless you have surgery that is corrective surgery, you're going to continue to have this problem. Like our patients who had a Charcot, those are progressive. The Charcot you had last year may not be the Charcot you have now, right? Because every time it gets hot and it gets inflamed, then you start having, all of that demineralization of the bone again, and it'll end up collapsing even more. So, that's such an important thing for patients to understand. And through remodeling, I have to tell you, I can't tell you how important that is. And it's just real essential. It's just absolutely essential for patients to have a good outcome. I don't know if you've ever heard of Dr. Paul Brand. Dr. Paul Brand was a physiatrist. He was at Carville, and he was actually the medical director of the Hansen's Disease Center when all of the research was being done. And it was really, this is one of his old slides from like the 60s, I think. And it's, basically he said neuropathic foot wounds are more a matter of mechanics than they are of medicine. All right. So I love this slide though. It says, the little cartoon, it says there's no ulcer medication worth walking to get. Okay. So that's my whole point about, yeah, we can put a skin sub on it, some kind of a tissue-based product. Sure, we can do that. But if the patient gets down and they walk on their wound, then, that's just not going to work very well. It's not going to work at all. So one of the things that we learned was, I will tell you this, in our program, we had a shoe shop, and we had pedorthists, certified pedorthists, and we could make, honestly, we could fashion shoes for the most significant, complex foot deformities from skeins of leather and different types of offloading materials, okay? If it was a foot that was quote unquote shoeable. So when we first started, they were so excited that I wanted to do this work, and it was just kind of like one of those things. They're like, okay, we're going to get you a grinder and we're going to get you a this and a that. And I'm like, look, I do ostomies too. I see patients who have all kinds of wounds. I can't do all of that. What I need from you is something that is off the shelf. Okay. That with very minor customization would be great for my patient. Okay. Didn't have to do a lot of fabrication to it. So these are some examples of a variety of currently available offloading options that are off the shelf. And as you'll see, these are from Darko. There are other folks that make them. They certainly do. I'm going to be very frank with you. We did a lot of our studies on some of Darko's original shoes that they had available. And one of the things that we realized early on was that it was a very cost-effective way for us to be able to take care of our patients. Okay. I had docs. I mean, we could do total contact casts all day long, but the problem is not everybody can do that. And there are a lot of issues sometimes for casting, particularly, just the expertise. And then some patients, are not appropriate for a total contact cast. So there are a variety of things. So these were all different options that are available. So, with the Charcot, I will tell you, pretty much you're going to need something like a TCC or, an irremovable walking splint. And I have to tell you, one of the funniest things that David Armstrong ever did was when he started talking about irremovable walking splints, they would zip tie them on the patient's leg. They never came off. They didn't come off, which is a little bit kind of scary, but I trust David a lot. I trust him, and I don't think he had any bad outcomes from any of that. And what it showed in the research was, if you're able to remove that high pressure off of the wound site, redistribute it over the remainder of the foot, you could very successfully assist these patients, toward closure of their wounds. Now, one thing I do have to tell you is total contact casting is not like a typical fracture cast. It requires very specific training, and that's why a lot of folks don't do it. And you got to remember these folks are insensate. So if you say to a patient, okay, if you start feeling a rub, you need to let us know, they're not going to feel a rub. So the last thing we wanted was for a patient to come in and then we had actually created a wound because they had a total contact cast that was not properly fitted. So here's one of the things I also like to show is pressure mapping, and it's on all of these different shoes that are available off the shelf from Darko. Okay, and these are F scans, as you can see. Now, one thing I'm going to tell you is, okay, this is the original. Okay, and that's great, but that was really more designed for fabrication. And I'll still see people walking around on, on these, and, there's just not a lot of offloading with that. There's not a lot of pressure reduction with this. As you can see, these are the areas when you see the yellow in particular, where you've got, the highest pressure. So what they did was then they kind of fashioned a different type of a post-op shoe. And this, as you can see, has a little bit of a rocker. And when you use a rocker, one of the things that happens is as the individual is walking, they kind of glide through the step. Whereas there is no point where you have focal pressure at any point as they're moving forward. Okay. Now, not everybody's appropriate for a walker, but a lot of folks are. A lot of folks are appropriate for a rocker. Okay. Then we have the Peg Assist. I don't know if you're familiar with this. These are available. These are really very reasonably priced. They've got great studies. As you can see, when you just have a patient that just has the standard med-surg shoe, okay, here, this is, you do get some pressure reduction here. And as you can see, it does have a soft insole that's in there. But with these Peg Assists, the way these are designed, I mean, you've probably seen some of the walkers, the early walkers that had something like a peg, but the problem was the pegs were in the interface with the foot. And, as I indicated, these folks have a lot of times some gait abnormalities. So, they're shuffling and they have some shearing when they're walking. So it kind of bottoms out the pegs, and, you don't really get much effective offloading there. Whereas with this one, the pegs are on the underside, and then, you identify the site of the ulcer and where it needs to be offloaded. And then you have this nice little piece here. It's kind of sandpapery like on one side, so it doesn't slide. And then the other, this is all adhesive. And that individual, you just take it and you just slap it on the bottom of this this insole, and they don't come out. Okay. Another, okay, here's our standard again. And then you've got a patient who has, like, say they have a heel wound. Okay, well, that's great. So you've got this and you're kind of missing the back part of this, right? But look what it does to the forefoot. So, clearly you don't want to walk on the heel. So you're shifting the pressure to another part of the foot. And in this case, it would be into the forefoot. Now, as long as they don't have forefoot issues, that's okay. But, you don't want folks walking a whole heck of a lot when they've got this kind of thing going on. And we know that we're moving that pressure distally. And then again, here's the standard. Okay. Just the med-surg shoe, post-op shoe. And then this is one that we actually did some early research with the Ortho Wedge. And, we use that particularly for forefoot wounds, forefoot. Okay, so we're talking about met heads and toes as well. And if you walk on your heel, one of the things you'll notice is you'll get a very natural type of offloading, because when you walk on your heel, your toes are going to flare up. Okay, so that's a good thing. The only problem that, and you can see, look at the pressure reduction here from just the standard to this. Of course, you're moving it here on the heel. As long as they don't have issues there, that's fine. The only thing I would tell you that is a little bit of concern with these, some people love them. We used a lot of them, but we only did them if the patient had some stability. They had to be stable. And the other thing is they had to use an assistive device of some type. And we saw really good outcomes with these, but again, they're not necessarily for everybody. So these were the different types of assistive devices. These are very popular now. And of course, walkabouts and walkers and that kind of thing. We used to have on here crutches, and I took it off. That's kind of a hazard. It's hard enough for these folks. I mean, think about it. With their neuropathy, they may not know when their foot is striking. They've lost proprioception. They may be, again, they are trying to manage crutches, and their offloading device. So something that provided a little more stability was particularly like a walker, or these walkabouts are kind of really nice. So these were some of the really, really low-tech offloading options that we did. And we made these, and I have to tell you that the cost for this is probably about 25 cents. And when I wasn't really busy, I made lots of these. And then as I needed them, I would customize them for the patient. And so this was what was called a Crest Pad. This is an old podiatry method of dealing with claw toes. But look how effective it is. Okay, so this is gauze that is rolled up. It's covered with moleskin. We put a little thing up here, a little mark, so the patient would know that's where it went on the top of the foot. Of course, it was easy to know after they'd walked on these for a while, because they would come, you talk about very customized, they would have it was just really beautiful how, the toes would fit right in there. But you can see now when this individual steps down, the pressure's going here. It's not going here. And these are those claw toes that we were talking about. Okay. So that's a really cool thing. Now, the good news is there's some more current options that don't take quite so much effort. They're more expensive than a quarter, but they're readily available. You can get them, in a lot of, I'm sure some of the places where you obtain some of your offloading for your offices, offloading supplies. Quite frankly, this was on Amazon. So there's just a variety of places that these are available. And what's nice about this is it's a gel cushion underneath here. And so just as as you just saw with the moleskin under there, the foot, the distal toes here are not going to be striking on the, when they take a step. So that's a good thing. Silicone's a lot of times used as well. Another cheapy option that we did was adhesive felt pad. We used 1/4-inch adhesive felt. We would skin prep the bottom of the foot. We would take before that, we would put a transparent dressing down. We would lipstick wherever the wound was. And then we would take our piece of adhesive felt that was cut to the shape of the patient's foot. We would back it up to it on the side that we were going to have against the foot. And just make a cutout for it. We skin prepped it, and then we put those on. Now, we liked to put our adhesive felt pads kind of like distally a little bit more than a lot of folks do. I don't see that so much now, but we felt like we got better results when we did. Unfortunately, I don't have time today to talk a whole lot about the studies that we did, but we were able to show some really significant outcomes by using these. And we had patients who we would say were kind of addicts. They were felt pad addicts, we would call them. But, it's great. The other thing we never would tell a patient is we knew that they got up in the middle of the night and did they put on their offloading shoe? No, we knew that didn't happen. At least not most of the time, I would imagine. And so what we didn't tell them was, and this was one of the studies we did, if someone had this on their foot and they walked with just this, they still got real substantial offloading. Okay, so that was a really kind of a nice aside to what we did. Now, as a wound care specialist, I have to tell you, this was like a big deal to me, because I would say to Dr. Burke and Dr. Patu all the time, okay, so what are we going to put on the wound? And they're like, well, what do you want to put on the wound? And I'd be like, well, don't we need to put a dressing or something? And they're like, you need to put nothing on this wound. Okay. It needs all the pressure needs to come off. We would maybe do like back then we had Panafill and Accuzyme if we needed that, or, we could put a dressing on the outside, but we didn't like stuff this with dressing material, because it really would interfere with the offloading. And I can tell you, I used to do a lot of talks at conferences for my nursing organization. And when I would tell the other, wound care specialists about this, oh my gosh, they got so upset that, they just thought I'd lost my mind. But I can promise you that, just take the pressure off. I think Dr. Armstrong did something. It's not what you put on, it's what you take off the wounds that helps them to close. So here's some more current adhesive felt that you can use. These are already cut for you, which is great. This is just the roll. This is what we used to use. And And again, it's 1/4 inch adhesive felt. Another thing that we would use, and you may have these available to you. I have patients who, if they had foot deformities, they'd go ahead and buy one of these. Now, it's called a ball and ring shoe stretcher, and you can use it for folks that have, those toenails that are just, I mean, I know you've seen them. They come in and their toenails are, like a mountain. But then you can also use them for like bunions and different areas like that. The only thing I'm going to tell you, from my personal experience, is if you're going to do a search, if you're going to do like an online search for this, it is really, really important that when you do your search that you say ball and ring shoe stretcher. Make sure you include shoe, because I'm not going to tell you what'll come up, but it may not be exactly what you want. And you sure don't want to do that kind of a search if you're like at work or something like that, because it's not really anything having to do with offloading at all. I'll let you figure that out. The other thing that we would have is like some of these for bunions, and so these are kind of nice. Okay, these would separate these toes. So these were silicone separators and pads, and they're really great for bunions and that interdigital issue. So what did we see with our offloading? How did we know, what did we feel like were the caveats that said, okay, these are your outcomes and when healing is going to be demonstrated? And so we would see certainly decreasing wound dimensions, improvement in that wound bed and the tissue integrity, and then the temperature difference. There was no way we could have done this program without using infrared temperature monitoring. Just couldn't have done it. That's how we advanced our offloading. That's how we knew, just an awful lot of what was going on with that patient. And, it's the most amazing thing if the patient isn't stepping on their wound. It's just crazy because that infection kind of goes away. All those things that were issues, and we know infection is a big reason for amputations. And in our program, if a patient, if they had osteo, I mean, we would try to do as much as we could for them. And sometimes it was, it would resolve. But what we would see was once we really did remove the pressure, it was amazing how you'd see so much resolution of those other problems that originally you'd seen. Okay. I like to say that when you're not offloaded, you're assaulting the foot with each and every step. Okay. If you're just walking on it with no attention to the wound and what needs to happen for that wound to be offloaded. Want to just mention this to you real quick. I don't know how familiar you are with it. Dermal thermometry, it's infrared. That first one you see, that was the one that I used. It's not made anymore, but it's non-contact. Okay. And I told you about the dermal temperature monitoring and the $14.99 option from Radio Shack. Now, granted, it was not tested on humans, but once I started looking at it, I didn't realize how many different industries actually use infrared temperature monitoring. I mean, it's like the folks that do like air conditioning and folks that work with like different types of metals and that kind of thing. They're, something that you really can't touch. Even the ones that work with folks like in zoos who work with like venomous animals, they use these very effectively. Now, thanks to the little kitties, they really developed pretty quickly some human grade infrared temperature monitoring. So those are widely available now. Some are better than others. You don't have to spend a fortune on them though. But now there are some other options that have developed over time. The first one there is it's a mat. Patient stands on it and for 20 seconds, and then it will give a reading that goes to a dashboard, and it will basically show you several different places on the foot and just give you like trending and that kind of thing over time to identify if you're starting to see temperature issues. Because remember, temperature elevation in that temperature above 2.2, that is inflamed. That's inflamed. Otherwise, and see, that's the other thing with these patients. You can't just look at somebody who has a diabetic foot and say, oh, that's inflamed or it's not, because, sometimes infection and inflammation do not present the same way among that population as they would with someone who doesn't have the neuropathy and diabetes. And then this other is something called a smart sock. And it's a very cool thing because essentially you can see there's a little kind of a sensor there on the side of it. And that will give you an idea of different temperature readings over a variety of sites on the foot as well. All right. There's a lot of education that needs to go with this, but I have to tell you, I had a lot of patients, and we're talking about, for the most part, they're folks who didn't make enough money. They're working people, hard working folks. I live in New Orleans. I live in the New Orleans area, and these were folks that worked down on the river, and a lot of them didn't make enough money to have insurance yet. They made too much money to be on Medicaid. And so they wanted to be working. So they would go and they would get their thermometer and they would check their temperature, and they would, if they started having issues, they would call me and say, okay, my temp's up. And it's like, okay, where's your offloading shoe? We had a routine that we just followed with that. That is not a hard thing to do. It is not a hard thing to do at all, but it's so effective. And the other thing that you're doing is you're giving the patient the ability, you're enabling them towards self-care, which is, that's the beauty of it. That's really, really where we want this to go. I don't want patients to need me forever. Okay. I want them to be able to draw some conclusions and know what's going on. Using monitoring of this sort, particularly pressure monitoring, like with insoles, there's some insoles you can do. And then the, infrared dermal temperature monitoring. Those are great opportunities for some of the remote patient monitoring systems. Like in our program, we also can do the telemedicine piece. So if I have a patient who's having issues, I can also say, okay, I need to look at your foot. And, using smart technology, it's great. I can actually look at the foot as well. I would never presume to talk to you about reimbursement for the remote patient monitoring because I don't think I would represent it properly. But what I will tell you is there are ways to do that one, are very effective for your patients. Two, they keep them in your system so you know what's happening with your patient. And then three, you really are able to monitor them. That's a win for everybody. It really is. You've just got to know what is that foot, that risky foot that you would be dealing with. I want to give a shout out to this group, the International Working Group for the Diabetic Foot. I don't know if you're familiar with them. If you aren't, I would encourage you, please go online, just put in international IWGDF, and they have a variety of different guidelines. They have practical guidelines, they have offloading guidelines, infection guidelines that are with the Infectious Disease Society. It's all very current. This is a global group. Probably anybody we would mention tonight in the US who, Dr. Rogers, Dr. Lavery, Dr. Armstrong, all those guys, they're very much involved in this. They don't run it, they're doing their own research here, but, the UK, they are really on top of this type of care, okay, because it's very much, keep the patient out of the hospital. What are the things we can do to identify the problems on the front end so we're not having issues on the back end, when it's too late to really do anything. So I would encourage you, please, check this out because it will give you a beautiful model to follow in your practice, in your offices. And then just in summary, offloading pressure, it's management of tissue loads essentially. And it's really the foundation of neuropathic wound prevention and management. Now, again, I'm not talking about PAD wounds. I'm not talking about so much neuroischemic wounds. And let me just mention one thing about that. We knew our limitations. We weren't a vascular group. So if we had patients who had those issues, we got them to the vascular service. Okay. If they could not be revascularized or whatever, then we tried to manage them as conservatively as we could. And sometimes that worked out great. And sometimes, it maybe didn't. The other thing I would suggest is offloading. It should be a first thought. It's not an afterthought. It is a first thought. And at the time when you're doing that comprehensive foot exam, that's when you identify this is what this patient's going to need. Okay. And then again, there are many inexpensive off-the-shelf tools and well-demonstrated alternative offloading methods to total contact casting for sure. Okay. That are available. And those are some of those that I showed you. And I want to thank you for attending. I hope this was beneficial to you. I know it's not real high tech, but it's really a way that we can begin to impact those numbers, because one of the things that we saw, good heavens, was between 2009 and 2015, the amputation rates, they doubled. They doubled. There were things that happened, like, for example, in California, Dr. Lebovitz, he did a study, and essentially what he found was when their Medi-Cal, stopped paying for podiatrists, people didn't refer to podiatrists, and their amputation rates went up 40 to 60% pretty quickly. So these folks just need routine care. They don't necessarily have to have the high-end stuff, but they really need the routine care. And I don't know what happened to my statistics. I had a whole thing with statistics, and I guess it just kind of left. Sorry about that. But anyway, that's it. And I want to thank you again. And if you have questions, I'm sure we'll be happy to answer them.
Awesome. Thank you so much. And so while we wait, while questions are potentially being generated, Ann and I always kind of get the ball rolling with questions initially. So obviously we know that Darko is sponsoring this webinar, and during your presentation, you mentioned some of those products specifically. I'm not muted, am I?
No, you're good.
Okay.
I hear you.
Perfect. So one of the products that I know John had mentioned to me, this was several months ago when we were talking about getting involved with partnership and really training individuals on the Pegasus product. With your experience with that product, what would you say for anybody who is thinking about bringing that product into their practice would be maybe some initial challenges, or just what is the best way to dive into getting that product in the practice and really making it work?
Okay, the first thing I'm going to tell you is it's very effective. It's not real expensive. I can't talk to you about reimbursement, but what I can tell you is the pricing is so reasonable that a whole lot of patients can just purchase them. Okay, so you would certainly need the proper type shoe, the offloading shoe to use that with. I will tell you this, one of the things that those guys have done really, really well is their instructions for how to use these different options. I mean, it's like, it reminds me of Dick, Jane, and Sally. You're probably too young. You don't know who Dick, Jane, and Sally are, but that's how I learned to read in first grade. And they were just beautiful, just little cartoons, little images, but that's what these are. And so it's not a difficult thing to do at all. And these guys are really good about providing education and that kind of thing. So what I would tell you is I think it's extremely effective. And again, it's not going to break the bank at all.
If I may interject something, if everyone can hear me.
We can.
This is John from Darko. The greatest thing about the PAG is it's, as Myra said, it's off the shelf. It's inexpensive. For lesion grade 1 ulcerations, it's ideal because patients find it very comfortable. The offloading is immediate. You get about a 65% pressure reduction immediately to the site. And it's low profile. When you pair it with our medical surgical shoe or the Duo shoe or our all-purpose boot, it's low profile, meaning there's not a great leg length discrepancy. There's very little hip or knee displacement. The patient's able to ambulate fairly normally, and it's not going to affect that gait pattern, but yet it's still going to cut down on the shear. It's going to offload immediately and hopefully, enhance that healing process.
Okay,
Yeah,
sorry. I was muted.
sorry. My kids are having a Nerf battle in the background, and so I don't need that sound coming on. So that Pegasus product is one of my favorite things that you guys offer because it is so customizable, and
Yeah.
it's something that physicians can stock in their office and customize it for the patient right there. They don't have to, order it or anything like that. They don't have to say, well, I don't carry that particular pad in my office right now. Give me a few days or something like that. So it's something that you should purchase stock of to keep in your office so that you're always ready for, the patient that might need it.
Yeah,
You know-
exactly. And that's a great point. Our products are very inexpensive. The PEG's going to cost you less than $20 from our distributors, and we have distributors throughout the country. And then the medical surgical shoe, around 10 to 12, the all-purpose boot around 14, 15, et cetera. So it's easy, it's quick, it's comfortable for the patient, and we've done very well with the PEG. It does a nice job in offloading.
You brought up one point though that I really is so important. I'm a wound care nurse, so as I said, I learned so much from my PTs. But for other folks who did the same kind of wound care nursing, this was not something we really learned when we were in school at all. We learned about it, but we didn't really understand it as intimately as I realized I needed to. So one of the things to me that was so important, and you brought this up, you've got it right there in your office. I mean, to me, the worst thing that could happen for my patient was if I, messed around with their foot, their wound, and whatever I was going to do, and then just had them get down and walk to another department to get their offloading shoe. I mean, it's just like, no, you don't want to do that. So while I was at the foot of the patient is when that's when all of my offloading happened, was when I was right there with the patient. And I don't know, I think that is just so incredibly important. It really is.
Yeah, I agree. Very good point. Good point.
Obviously, this topic is very, sorry, go ahead, John.
No, I was just going to say, if anyone out there would be interested in more information or a sample of any of our products, they can contact me. They can go on our website, and we'll be happy to send them a sample at no cost.
We do have a question that just came in. John, does Darko deliver the shoes overseas?
We do have different divisions. We have a division in Suffolk, England. We have one in Reichsting, Germany. And we also have one in Shanghai, China, and Dharwad, India. So globally, you should be able to access our products. If you're speaking of England, Europe, you can get those products fairly immediately and fairly quickly. Darko USA, which is based in Huntington, West Virginia, we handle North America, and we can get that to you fairly quickly as well.
Okay. And then we did just have a chat come in. Angie Fizel, I'm sorry if I pronounce your name wrong. She would definitely like to know more about the product. So, John, I believe I have her email address, but we'll just have to follow up with her. And while we're talking about how to get our hands on the Darko products, what are your most prevalent distributors in podiatry?
In podiatry, our big distributors are Gill Podiatry. They're probably our most dedicated podiatry distributor. You have Henry Schein, you have AliMed, we have Chicago Medical. The products are available through McKesson. Not all the McKesson DC stock our products, but I would say the first 3 or 4 that I mentioned are really sure bets for product availability, good pricing, and prompt service.
Just like you.
Yeah, we try.
Yeah,
We try. Yeah.
John's always on the ball, so we appreciate that. I had just a quick question that I don't know if this, John or Myra, either one of you, maybe would have some insight. I know I don't know the practice types of, obviously, the people online are physicians or DPMs, but I'm not sure if they really specialize in diabetic wound care. Often we hear DPMs referring these types of patients out. What do you say to physicians to DPM specifically, who may be referring diabetic patients out instead of keeping them in their practices. Just what are your thoughts on that?
Okay, I'll say something. Well, one is, I think I've really tried to bring home the point of how important, this is just such a basic thing that's got to happen. Okay, so the offloading is definitely it. The other thing is, it's really not hard to get wound education now, and very specific to the diabetic foot. It's not difficult to find that. And if it's somebody that's really interested in that, I would tell you, oh my heavens, you have availability. And again, like I said, with the remote patient monitoring, one of the things we love about doing it is our patients keep their patient. Our docs keep their patients. They're not losing them to a wound center. And I can say this because I was the chief nursing officer for a wound company. It was not a hospital-based company, but we had over 100 wound centers in 14 states. So I can tell you all about how that business is. And sometimes it was great, and then sometimes it kind of wasn't. And I didn't see a whole lot of what we're talking about today. I didn't see that happening at all. And it's just so basic. It's just so basic and so important. And I guess my point that I really want to hopefully folks are getting clearly enough is that, when you identify that person has got that, whatever that abnormality is, if it's a deformity or the gait abnormality, or they've got the flexibility issues, oh my gosh, that's the time right then and there. That's the time to go ahead and, start working with some of this stuff. And again, remote patient monitoring is really a way that's not a big time constraint for you, and one of the things that we really enjoy doing is we check on those patients. And as I said, if a patient's got a wound, I've got standing orders, it's like, okay, Mr. Jones, we need to take a look at your foot. Let's see what's going on. Okay. You hope that patients have really good foot care routines. Some do, some absolutely do. Some don't. And so, that's all kind of, for those patients you're particularly concerned about, I would tell you that that's a beautiful way to go.
Well, and obviously patient education is super important. And then the practices, they definitely will, because you had mentioned a little while ago that regarding billing and coding. John, does Darko have tools to help physicians with the compliance part of dispensing these types of products?
If you're speaking of either just guidelines that we go by in terms of product adherence and product longevity and use, et cetera, we can help you with that. The products, if you're speaking of reimbursement, those type things, most of our products have reimbursement codes. Now, as to the actual reimbursement the clinicians would receive from the products, that depends. I do know for a fact that private insurance is more generous in reimbursement than Medicare on several of our products. But again, the nice thing is, going back to the cost factor, our products aren't that expensive. So again, they're very reasonable price, I think, when you look at the grand scheme of all the products out there. So hopefully, a clinician may not have to stock a bunch of products, but they can stock enough to help a vast majority of their patients. That's why I like to refer back to the Pegasus and the all-purpose boot combination, or the Pegasus and the Duo shoe combination. Those are just two products, but those two products can usually offload lesions, grade 1 ulcerations for a vast majority of their patients. Toes, forefoot, midfoot, heel. And you don't need any other products, special products for that early intervention, which is what we like to do.
The only other thing I'm sorry.
Yes.
Okay, good. Sorry about that.
The only other thing I wanted to add was, as we are moving closer and closer to value-based care, and we've been hearing about this a long time, but it's going to happen. It's happening in some. It's happening in some of the different venues of care already. Our company is a value-based company.
And they do a great job.
Well, but this is an area, you know, in your practice it's going to matter. It's going to matter the outcome of your patients early on to prevent those amputations, you know, and foot ulcers for that matter.
We had a question come in about will people be able to view the recording and download the slides? We do always put the recording on our website, so you can see any of our older webinars there. They're on our archives page. I will try to remember to send out an email with this particular recording. Myra, would you like to share the slides as a PDF presentation, like to send along with the email, or what do you think? To put you on the spot.
Yeah, thanks. You know, I'm happy to share whatever I have. The other thing is you have my email address, and email me. You know, if there's something I can do to help you, I'm more than happy to do it. You know, I mean, whatever we need to do, you know, we're more than happy to help with.
Okay, super.
Awesome. Well,
All right. Well,
I don't think we had any other questions come through. I was just going to remind everybody to go to the online booth. And did you have something else?
no, just, you know, thanks everybody for your time, and thanks Myra and John for putting this together. It was super informative. So yeah, Sarah, what's going on at their booth?
So, well, it's just there. So always remember that we do have our podiatrymeetings.com marketplace, and Darko is a part of that marketplace. So if you go to our website, go to the marketplace section and scroll down to Darko, you can see a bunch of resources there. We've got informational videos that kind of talk about the history and the impact of Darko with, you know, and not only just what their products do, but how they've impacted education. And you can see training videos on the Pegasus specifically. The product catalog is there. Obviously, you can go to their website as well. We've kind of condensed everything on podiatrymeetings.com though. So if you are going there to maybe rewatch this recording of the webinar, sign up for other webinars, don't forget to go to the Darko booth at podiatrymeetings.com to see featured products, get product catalogs. There's a request more information form right there. So we just try to make it easy for you to get the information that you want from our sponsors. So that is available to you at all times.
Yeah. Awesome. Well, thanks again, Myra and John. Do you guys have any last minute thoughts before we all go tuck ourselves in?
I just want to say thanks to Sarah and Ann for allowing this to happen. We appreciate it greatly. Thanks to Myra. As always, a wonderful job. Myra's a great wealth of information, as we know, and appreciate everyone's time, and thanks for listening in and watching.
Awesome. Thanks so much, everybody. Good night. We'll see you in a couple of weeks for the next one.
Yeah.
All right. Thanks.
Thank
Good
you.
night.
Good night.
Bye-bye.